Medicaid Long-Term Services and Supports webinar. My name is Michelle Soper, and I'm very pleased to see the large number of people on the phone who are participating in this webinar. I'm going to tell you a little bit about the project, which the Center for Healthcare Strategies and Manatt Health are partnering on to work with select states that are committed to pursuing LTSS reform and disseminating information about effective Medicaid LTSS strategies and best practices through a comprehensive toolkit. This toolkit provides a targeted menu of LTSS reform strategies, and this webinar will review some of the key features of this webinar. So first, for the introduction, I'll give a brief welcome and introductions and introduce our speakers in a moment, then provide a little bit of background and context for the project, and then I'll turn it over to a fantastic list of speakers here to give you a little bit more detail about the content. So if we could advance actually 2 slides, please, to the presenters. Perfect, thank you. So as I mentioned, my name is Michelle Soper, and I'm the Director of Integrated Care at the Center for Healthcare Strategies, where I work on activities and projects related to integrating care for individuals who are duly enrolled in Medicare and Medicaid. I work with Alexandra Cruz, who is a Senior Program Officer at CHCS and has many years of experience working with Florida's Medicaid program, where she helped to develop a managed long-term services and supports program, and also worked on a nursing home transitions program. She also ran the state's health insurance program for Medicare beneficiaries. And just to back up one moment too, CHCS, just to give you some background now, is a national nonprofit policy center dedicated to improving the health of low-income Americans. We work with state and federal agencies, health plans, and providers to create programs that better serve beneficiaries of publicly financed health care. Next, we have Stephanie Anthony, who is a senior advisor at Manatt Health, where she provides research, analysis, and advisory services on health policy and health law to public and private sector clients. She has several years of experience working with the University of Massachusetts Medical School Center for Health Law and Economics, and has served in many posts in Massachusetts Medicaid program, including Deputy Medicaid Director. Manatt Health is a division of Manatt, Phelps, and Phillips, and is an integrated legal and consulting practice with over 90 professionals that support states, providers, and insurers in navigating the very complex healthcare policy and regulatory landscape. We are also thrilled to have 2 state participants in the webinar today that have made very impressive strides in developing top-notch LTSS programs, which are featured prominently in the toolkit. Our first state presenter will be Patty Killingsworth, who is the Assistant Commissioner for the Bureau of TennCare, and the Chief of Long-Term Services and Supports. She's worked in Medicaid programs in Missouri and Tennessee. And in Tennessee, major efforts include a managed long-term services and supports program that she led the launch of in 2010 that has significantly expanded access to home and community-based services and includes a new model program for individuals with intellectual and developmental disabilities. We are also very happy to have Tammy Whitlock, who is the Division Director for Integrated Care at the Virginia Department of Medical Assistance Services. Ms. Whitlock oversees the Commonwealth Coordinated Care Plus program, which is Virginia's managed long-term services and supports product. And prior coming to DMAS, Tammy has worked in areas of physical rehabilitation, mental health, and juvenile justice. And before we move on to the webinar, I want to thank our funders, the SCAN Foundation and the Milbank Memorial Fund, whose generous support allows us to facilitate this webinar and engage in other project activities. So thank you on behalf of CHCS and Manatt. Okay, so we'll skip 2 more slides to number 6, please. Thank you. Perfect. A couple of logistics before we get started into the presentations. First, to eliminate background noise, phone lines are muted during today's event. If you'd like to submit a question, you can click on the Q&A icon that's located on the bottom of your screen. I'm going to give a very quick overview about why we focus on LTSS and some of the context for this project. So Medicaid beneficiaries who use long-term services and supports are among the most vulnerable, complex, expensive, and fast-growing populations covered by the program, comprising about 1/3 of the program's total spending, and is projected to grow 3 times as fast in coming years. This is primarily due to the aging population's projected growth. Those over 65 are expected to grow by 18% by 2020 and double by 2060, which will only increase the demand for LTSS and put more pressure on Medicaid on both the federal and state levels. So as a result of many of these challenges, several states are seeking to reform their Medicaid LTSS systems to improve both the quality of care and contain program costs. Next slide, please. Okay, why don't we start with the methodology? The toolkit is that we put together, that CHCS and MNAT developed, is intended to assist states in identifying concrete policy and programmatic strategies, operational steps, and available federal and state authorities in LTSS reform areas, as well as identify reasons why states have utilized different strategies and some of the challenges that they faced in designing and implementing these reforms. To develop this toolkit, MNAT Health and CHCS conducted several interviews with experts and implementers in innovative states to understand the basic reform strategies, try to illuminate some of the specific leading practices through case studies, and also identify considerations for when and how a strategy might be employed. We also had a project advisory committee that provided critical guidance at each stage of the toolkit's development. Thank you so much. And now I'd like to turn it over to Stephanie Anthony to talk about the first set of strategies in the toolkit.
Great, thank you, Michelle. So I'm going to focus on rebalancing of Medicaid LTSS, and by rebalancing we mean shifting spending and utilization from facilities-based settings to community-based settings, and really trying to match care settings to individuals' needs in the most appropriate way. So many states have made significant progress in rebalancing their LTSS systems. I think an earlier slide, if you saw it, said, showed that over half of total national Medicaid LTSS spending is for community-based care now. I think it's at about 55%, up from about a fifth or 18% just over a decade ago. But there's still, while there's, states have made significant strides in this area, there's still more rebalancing work to be done, and there remains significant variation across the states in their level of HCBS spending, ranging from a high of 82% in one state to a low of 31% in another state. And also across rural and urban settings and across different populations within states. And in many states, there are more rural residents who remain in nursing facilities. And across certain populations, for example, there's higher community-based care utilization rates among populations with intellectual and developmental disabilities in some states than there are for seniors and adults with physical disabilities. So still a big focus of states and still a lot of work to be done. Next slide, slide 12. Great, thank you. Historically, most publicly financed LTSS, long-term services and supports, was provided in institutional settings. And this is because of the statutory and regulatory structure of Medicaid, which makes nursing facility services a mandatory Medicaid benefit. But most home and community-based services, particularly non-clinical services like case management and personal care services, optional and only available to people at an institutional level or higher acuity of care. And that's what people refer to as the institutional bias. So historically, Medicaid and currently, Medicaid's not really structured to support an individual choice of setting or even the setting of care which might be most appropriate to an individual's needs. Today, nursing facility care remains mandatory and most HCBS remain optional. And often are covered through 1915C waivers, which have wait lists, so there's some limitations there. But changes in federal laws in the 1990s and more recent federal Medicaid flexibilities created by the Affordable Care Act in 2010 have really dramatically expanded states' abilities to provide care in the community. These changes have been prompted by individual and family preferences, which are vastly biased towards the community, increasing state interest in providing care in the highest quality and most cost-effective care setting that's appropriate for an individual's needs, and legal obligations created by the Americans with Disabilities Act for states to provide care in the least restrictive setting. To date, rebalancing activities have mostly focused on expanding access to services through 1915C waivers that provide a range of mostly non-clinical LTSS to targeted populations such as frail elders or people with intellectual and developmental disabilities or with traumatic brain injuries. Today, I think 47 states plus the District of Columbia operate over 340 separate 1915C waivers serving 1.5 million people. More recently, 17 states have taken advantage of one or more of the new Medicaid state plan options to expand access to HCBS. These are the 1915I, J, and K state plan options. And three or four states are using 1115 waivers to expand access to these services. Next slide, please. So we're starting to see some, newer strategies and innovations in states that have achieved some success in rebalancing as they look to continue reforms in this area. And these strategies include investing in the long-term services and support system infrastructure, access points into the system and the workforce to ensure that people can easily understand and access the services that are available to them and to meet the growing demand for LTSS as the population ages. Strategy 2 is around investing in nursing facility transition programs, which put supports in place to assist individuals in nursing facilities who are willing and able to safely return to and stay in their homes and communities. First strategy is around developing the LTSS system infrastructure to promote greater access to services. And states that are using this strategy are focused on strengthening the processes and systems that facilitate people's access to services, including strengthening the state's LTSS information and referral resources, typically through developing standardized and easily digestible information at each entry point or at a single entry point into the LTSS system, what people call a no wrong door approach, and then providing appropriate referrals that can connect people and their families to the services they need. Other states are implementing uniform needs assessments and person-centered care planning requirements across programs, and this can either be through fee-for-service programs, through Medicaid ACOs or MCOs that ensure or seek to ensure equitable access to services that's based on a person's clinical and non-clinical needs and their goals and preferences rather than their age or type of disability or which program they happen to sign up for. And a handful of states are working to ensure there's sufficient number of high-quality direct care workers, such as home health and personal care aides, to provide care to people, as well as supporting family caregivers who, by far provide the bulk of care to this population. States are using a variety of mechanisms to enhance the system infrastructure. You could see some examples here on the slide. The Federal Balancing Incentive Program, or BIP in particular, provided significant federal grant funding to about a third of states, most of which are still using these dollars to advance rebalancing goals through infrastructure development in these areas. While new BIP funding is not available to states, there are several other states who are using 1115 waiver flexibility, state appropriations in some instances, and creative provider and MCO contracting requirement to support these initiatives. And states that do have BIP funding are really now focused on developing sustainability plans to continue the work. Next slide. So as an example of strategy 1, Massachusetts received about $135 million of the total $2.4 billion in BIP funding to invest in its information and referral resources. They did this by by bolstering the choice counseling services provided by its Aging and Disability Resource Consortia, or ADRCs, and also by creating Mass Options, which is a single access point to the LTSS system for individuals and their families and caregivers and the public. Mass Options includes web information, online chats with specialists, a call center, and referral forms that people can fill out and be directed to appropriate services. One key lesson for Massachusetts and other states in this area was to start with a comprehensive landscape assessment, and other states use stakeholder surveys, broad stakeholder surveys, to gain a deep understanding of the existing system so you can then leverage what's there and strengthen what's there rather than start from scratch or recreate the wheel. And then that assessment or surveys also helps to identify gaps that help states decide where to prioritize their investments. These investments do work. BIP evaluations have shown expanded access to services through many of these mechanisms, whether it's shared information technology systems or uniform assessment tools, or workforce investment, and through BIP and other initiatives in Massachusetts, they have increased their HCBS spending from 45% in 2009 to about 74% today. Next slide, please. Strategy 2, this is again around investing in nursing facility transitions. I'm going to keep going and the slide will catch up. Investing in nursing facility transitions. Several states are focused on assisting people in nursing facilities to safely transition to and remain in their communities. Here, states are investing in 3 main areas, both in the fee-for-service system and in managed care. I'm on slide 16. Some states are investing in transition support services, such as housing assessments, the development of housing support plans, and assistance with the housing application process. Through the use of, some states are deploying transition counselors or housing coordinators, which they provide to people while they're in the nursing facility to help them identify, select, and then move to affordable and stable housing and community services. Other states are coupling transition support services with what is called tenancy sustaining services, which include small home modifications, environmental assessments, and education on tenant-landlord relationships or lease compliance. And these services are provided to folks post-transition, often for 6 to 12 months, to help people navigate and maintain their community living. A few states are developing affordable housing options in the community for people transitioning from facilities. As I think we all know, that lack of a stable and affordable housing puts people at higher risk of hospital and or nursing facility admission if their health or functioning declines. The federal Money Follows the Person Rebalancing Demonstration, or MFP, the funding of which is set to expire in the next year or two, provided the most direct source of federal Medicaid funding for these transition initiatives. But many states are also using 1915C waivers, 1115 waivers, and innovative managed care contracting requirements, whether it's through their rate development methodologies, programmatic requirements, and quality incentives and measures to actively support people's transition to the community. Slide 17, please. Texas used its MFP funding to create an innovative nursing facility transition pilot for individuals in facilities with serious mental illness and substance use disorders. They had been working on rebalancing for a good decade and realized that people in nursing facilities with co-occurring physical health and behavioral health conditions were particularly difficult to safely transition to and sustain in the community, primarily because they lacked specialized services and supports that they need to transition and stay in the community. The program covers cognitive adaptation training to help people establish daily routines, build social skills, make environmental modifications, and ultimately to gain increased independence. For people with substance use disorders, the program covers counseling, group therapy, and referrals to community programs to help people maintain sobriety in the community. And importantly, the program pays for these services for 6 months pre-transition and 1 year post-transition. Key lessons from Texas and other states around this strategy include the importance of using data analytics to identify priority populations for transition, so you're able to target your state investments appropriately. And then particularly with respect to connecting people to housing, affordable, safe, and stable housing, developing trusting relationships with and working collaboratively with from the start, which it takes some intensive work with a range of stakeholders, and typically includes some non-traditional partners like state and federal housing agencies, local housing authorities, private developers, and for states with managed care, often their managed care partner is critically important. Slide 18, please. The third strategy is around expanding access to HCBS for pre-Medicaid individuals. So a small but growing number of states are investing resources in what people call the pre-Medicaid or spend-down population, who are typically people at higher income than traditional Medicaid eligibility rules allow, and or who are not yet at a nursing facility level of care, and then providing these individuals access to a targeted set of home and community-based services to help them avoid or delay a higher intensity or higher cost nursing facility stay. States focused on this strategy, again, it's a small but growing number, typically use 1115 waiver authority and may often supplement it with state general funds to provide these services. These efforts are relatively new, so long-term saving estimates aren't yet available, but program satisfaction is very high and demand for the programs is high. There's, wait lists for some of these programs. Slide 19, please. So Vermont, which is highlighted on this slide, and Washington are examples of two states that have deployed this strategy. Vermont uses its 1115 waiver to create a targeted set of home and community-based services, which include case management, homemaker services, and adult day services for a pre-Medicaid set of adults, which the state defines as people at 300% of the SSI benefit level, who are assessed at having moderate needs for LTSS. And again, they use a state assessment to identify who fits into the moderate needs group and is at risk of institutionalization. And it provides a targeted set of benefits to these individuals to prevent their decline into a higher need category. The state will cover this group of individuals if there's funds available under the waiver's budget neutrality cap after they provide services to a highest need and then a high need category, and has committed to reinvesting any savings generated from covering this group into provider supports and services. Washington State also uses this 1115 waiver in a similar way. More recently, in 2017, they started this to create, again, something similar to Vermont in its Tailored Supports for Older Adults program. But they also created a second program called Medicaid Alternative Care that created a new benefit package that includes training, education, errand assistance, and support groups for unpaid caregivers of Medicaid-eligible individuals. Both Vermont and Washington have identified developing a solid risk stratification methodology as critically important, so they're able to identify the appropriate pre-Medicaid or at-risk group. They both noted that it's particularly important to use comprehensive Medicare data for dual eligibles, which can provide a picture on individuals' worsening health status, Medicaid data, and any social support data that's available to appropriately identify the target population and inform program planning. Next slide, please. I'm going to actually now turn it over to Patty Killingsworth, who is going to provide her insight on Tennessee's rebalancing successes and challenges to date, as well as the state's current initiatives and future direction around rebalancing and LTSS reform.
Thank you, Stephanie. I think that was a great overview of a lot of different strategies that states can use to really help in their rebalancing efforts. And I think as I talk about the work that we've done in Tennessee, I'm probably going to hit on each one of those on some level. For us, we really began this journey back in 2010 when we implemented our first managed long-term services and supports program for older adults and adults with physical disabilities. And since that time, have shifted our balance of enrollment from about 17% of the people being in community to now around 43% of the people in community. So a significant change over the course of time. And we've done that both through diversion and transition. I'll hit a little bit on both of those. But our first strategy was really around creating a global budget for long-term services and supports and beginning to bring nursing facility dollars together with home and community-based services dollars and really allowing people's choices to drive how those dollars were spent. We did that through the integration of both the nursing facility and the home and community-based services benefit into the managed care program. It's a piece of advice we often give states as they're thinking about implementing these programs is to really strongly consider bringing in the institutional benefit because it brings with it the ability to then redirect those resources based on the needs and preferences of people served in the program. When we created the capitation payment for the health plans, we created a blended capitation payment for all of the people who were nursing home eligible, meaning that the health plan receives the same payment, whether the person is in the nursing facility or in the community. And that payment is based on the historical experience in both settings and the current mix, with some moderate projections of how we expect that mix will change over the course of time during the rating period. What that does is then incentivize the health plans to want to support people in community and keep them in community. It certainly incentivizes them to want to make sure that people's supports that they receive in community are enough to safely meet their needs, because they'll then in turn be responsible for the more expensive institutional benefit, but won't receive any additional dollars for that. So that's been a really key part of our success. Excuse me, we have both transition focuses in the program, and in our transition focus, we have in particular leveraged MFP dollars to provide an incentive payment structure for our health plans. So the health plans receive an incentive payment for each person that transitions out of an institution and into the community under the MFP demonstration. They receive another payment when that person has successfully completed their 365-day stay. And we designed the MFP demonstration to be seamless, so that even when the demonstration ends for a particular member, their benefits continue on as is under the managed care program without any interruption in services and supports. We also have transition payments to the health plans for achieving other kinds of benchmarks that we have set forth in our MFP rebalancing demonstration, and have used those dollars to invest in housing supports, employment supports, other kinds of training that have really helped build the capacity of our system to support people transitioning to and staying in community. In addition, we have a strong focus on diversion, and here I've really used that third strategy around trying to focus on, in our case, elevating the level of care criteria for nursing facility services, while continuing to make sure that home and community-based services is more broadly available, including for people who would not qualify for that institutional level of care. So we do have a differentiated benefit structure that provides a more moderate level of supports for people who are pre-institutional. They are Medicaid eligible, but they're pre-institutional, and that has helped us substantially in keeping more people in the community, really changing the way that people come into the program from over 80% coming in an institution to now about a 50-50 split in terms of how people come into the program. Throughout all of this, I think our mainstay has been really working closely with our stakeholders, making sure that we are engaged with them as we think about program design, as we look at how the program is working, as we think about changes we want to make in the program going forward. Our IDD program in particular that we rolled out in 2016 is really reflective very directly of input that we got from people with disabilities and from their family members about how they wanted a new program to look and the kinds of benefits that they believed it really needed to offer. And then finally, I'll touch on what I think has been a really critical piece of working on the system infrastructure for us, which is around workforce development. We, like all states, are facing a workforce shortage. We have felt it acutely with the rollout of the second MLTSS program component for people with IDD, and that's really caused us to develop a pretty comprehensive approach to thinking about workforce, beginning with processes to collect and use workforce-related data at both the provider and system levels so that we can better target and measure our improvement over time. We have engaged with national experts, including the person who was very involved in the development of the report to the president on the workforce shortage, and are working to provide training and technical assistance to providers to help them support the adoption of practices that we know from the research have been shown to result in more effective recruitment, retention of staff, and in turn better outcomes for people who are served, including things like targeted marketing, realistic job previews, structured behavioral interviewing on the recruitment side, and then on the retention side, early access to mentoring, more effective supervision, and importantly, better quality training, which is the next component of our approach around developing a competency-based education and training program for direct support professionals. We want to do that in a way that will allow them to work and to earn college credit for the training that they are completing, and are working with our post-secondary system to create a pathway to a certificate and eventually to a degree program that can be earned by people who enter into the field, leveraging dollars that are available in our state, either for students who are coming out of school or adult workers who are returning to school in order to help defray those program costs for them pursuing that education. We also know that it's going to be really important that incentives are aligned to make sure that those solutions work. So we want to be able to incentivize data collection, reporting, and use for providers, incentivize them to adopt the evidence-based practices that we know will improve the outcomes, and then make sure that incentives are also aligned at that direct support professional level, so that as they increase their level of competency, they can then in turn expect a higher wage. So all of that together is really the approach that we're working on around workforce, and we think is critical to continuing to rebalance our system in Tennessee. And with that, I will turn it back to you.
Thank you. Thank you, Patty. That was excellent. Thanks so much for the comprehensive picture of all the work you've been doing in Tennessee. That's great. So I'm going to turn it over to Alex Cruz, who's going to talk to you about integration strategies.
Great. Thank you so much, Stephanie. And we're going to go ahead to the next slide, which is This is Perfect. I want to start just real quickly by presenting some background on the work that states have been doing and kind of the impetus for advancing integration of long-term services and supports before we talk about the integration strategies that are covered in the toolkit. State efforts to advance integration of long-term services and supports have grown very substantially in recent years. At this point, there are nearly a third of states that use managed care to expand access to home and community-based services, reduce fragmentation of care delivery, and for most states, look at how you can either better manage costs or increase budget predictability for some, or a significant portion in some states, a small portion in other states, but for some portion of their long-term services and supports populations. These programs are generally referred to as MLTSS, or Managed Long-Term Services and Supports. They really have proliferated quite a bit in recent time, and so there's recognition when we look at federal regulations that was put into place in 2016, which was changes to the federal Medicaid managed care regulations to include very specific expectations for both states and MLTSS plans, as well as enhanced consumer protections in a number of key areas. Additionally, there's a few things to point out that relate to the fact that states are relying quite a bit on managed care arrangements to advance integration, but there are actually far fewer Medicaid beneficiaries currently in managed LTSS programs nationally as compared to the proportion of non-LTSS Medicaid beneficiaries that are enrolled in Medicaid managed care. So there's a lot of potential for states to continue to replicate some of the integration strategies that we're going to talk about today. There are still also a lot of challenges when it comes to the diverse needs of the long-term services and supports populations that states are tackling. And the diverse and heterogeneous population essentially has meant that states may be using multiple strategies to address the needs of different segments of their LTSS beneficiary groups. And then finally, while our toolkit focuses on managed care strategies, there are also provider or delivery system-based initiatives that both states and stakeholders have undertaken, including things like for dually eligible beneficiaries, there's the program of all-inclusive care for the elderly that meets the needs at a provider level, as well as growing interest in the use of health home or ACO models to better serve LTSS consumers. Next slide, please. This is just a quick overview of the three strategies that are covered in the toolkit in terms of advancing integration for long-term services and supports. The first strategy focuses on better coordinating care for dual eligibles who are eligible for both the Medicare and the Medicaid programs. This population accounts for a significant share of both Medicaid LTSS costs as well as Medicare program costs, and their complex clinical care needs, their significant Medicaid covered LTSS functional needs, and routine gaps in care have made them a very central focus of state strategies. Additionally, we've got two other strategies that we'll talk a little bit about today. They both highlight growing state interest to use capitated managed care for LTSS populations that have been traditionally carved out of these programs. And so states are increasingly enrolling their Medicaid-only LTSS populations in newer existing programs. There's also a handful of states, Tennessee, which is one that we've already heard from Patty on, that have tailored program design under managed care to serve individuals with intellectual and developmental disabilities, also referred to as people with IDD needs. So moving on to the first strategy that we'll present a little bit of information on here, Medicaid agency efforts to integrate care for dually eligible beneficiaries increasingly focuses on contracting with Medicare dual eligible special needs plans, or a specialized type of Medicare Advantage product. These are referred to as D-SNPs, and as background, this type of Medicare Advantage plan limits enrollment to dually eligible beneficiaries, but also is required to sign contracts with the states in which they want to operate. So states have a lot of authority to be able to require various provisions in these contracts to better coordinate care. The D-SNP model is actually most effective in what we've seen across states and some of the work that's highlighted in the toolkit. When beneficiaries enroll in both an aligned Medicaid managed care product and a D-SNP plan. So essentially you have one individual enrolled in the same parent company. This aligned enrollment approach creates a lot of potential for sharing of clinical, administrative, financial data at the health plan level, helps to improve the coordination of care across the wide array of services that this population receives, and can do a lot of things that are really helpful from the beneficiary perspective in terms of simplifying materials that they may receive from their health plan. While our recently released toolkit focuses on D-SNP-based strategies, there are 10 states that have launched another implementation mechanism noted here, which is fully integrated programs authorized under the Federal Financial Alignment Initiative. I just wanted to point out that since this initiative is not open to new states, it wasn't a focus of our toolkit strategies. However, the ongoing work that's happening in those states has been a driving force for increased alignment on the D-SNP platform. There are also some results noted here, and I think one that I'll point out is some of the initial and I think promising results from D-SNP-based integrated programs, and one was an evaluation of D-SNP enrollees in Minnesota's Senior Health Options Program. That program, which was again trying to better coordinate and align incentives for care delivery for a very complex population, that program evaluation found that there was 48% less likely to have a hospital stay, 13% more likely to receive home and community-based services, and 6% less likely to have emergency department utilization than peers that were enrolled in Medicaid-only programs. Additionally, there are implementation challenges that need to be addressed early on in launching these efforts, and that is just essentially because of the complexity of trying to integrate both a state and federal program that have different rules and different processes and systems that need to be conjoined. There are two case studies in our toolkit that you can refer to. One is, well, actually, it's a joint case study that looks at both Arizona and New Jersey and kind of contrasts the enrollment approaches that they have undertaken to increase alignment for beneficiaries enrolled in their D-SNP-based programs. So next slide, please. So the next strategy that we can talk about here is integrating comprehensive care for Medicaid-only beneficiaries under capitated managed care, which really dovetails with just overall state efforts to launch managed long-term services and supports programs. The implementation mechanisms used by states vary, but generally states are combining authorities that may exist for Medicaid managed care in their state, also existing authorities for providing comprehensive long-term services and supports, including home and community-based waiver programs and some of the newer state plan options that exist for those services. The data that is available on this particular strategy in terms of results is somewhat limited because the states have launched managed long-term services and supports programs for different populations. It takes time for data to become available from how these programs are working, but there's actually not been any comprehensive reviews like across states of the outcomes. So last year, CHCS, in partnership with NAJUID, published results from a survey of 12 managed long-term services and support states, and was just kind of examining what at the state level may have been seen in terms of the impact of this strategy. And what we found in that survey was that several states reported improvement in quality of life for beneficiaries enrolled in these programs. Some saw decreased hospital utilization. Overall, there was positive impacts on rebalancing strategies that we just went through, and increasing HCBS access, as well as increased budget predictability. These are really promising results. However, there is a need for greater evaluation, but also challenges during initial transitions to managed care that are important to recognize. And really, states have focused on requiring close oversight and monitoring of health plans by their states and ongoing communication with stakeholders to make the implementation and the transitions to these programs as smooth as possible. In the toolkit, we featured Arizona, New Jersey, and Virginia as best practice states for this particular LTSS reform strategy. And in a few minutes, we will hear Virginia's perspective on the launch of their program. So the next slide. Great. So states, when it comes to trying to integrate and advance the level of coordination for individuals who have intellectual and developmental disabilities, are looking at, I would say, I think somewhat different approaches when it comes to using managed care. Some states have transitioned just physical health and or behavioral health benefits for this population into managed care as a starting point, and have seen some, I would say, strong uptake of Medicaid managed care for those who have opportunities to enroll. However, the most comprehensive approach underway at the state level has been to develop fully integrated managed care programs. These efforts seek to improve community integration for a population that values that. They also look at reducing fragmentation of care for individuals with IDD who have very complex care needs, and they receive often siloed medical and social services from their Medicaid program benefits. And so the programs that are designed to integrate care for this population have significant potential to improve service delivery that's pretty siloed at the moment. Similar to other MLTSS programs, states are using a variety of authorities to operate these programs. And while most states have enrolled individuals with IDD in managed care via 1115 waivers to date, New York recently submitted an 1115 waiver request to CMS that will actually improve coordination of care for this population by using the State Plan Health Home Authority that they have weaved into their waiver request. And so that will look at another type or another way of managing care and benefits for this population. Finally, the last thing that I wanted to point out here is that the results are pretty limited, since these programs are very new in a lot of states and operate in a handful. And we've listed some preliminary outcomes from Arizona and New York here and in the toolkit for those who are interested in some additional detail. The last thing I think that's relevant to share about these different integration strategies is that the lessons and the experience of states in launching and operating programs that advance this, these designs is really relevant across the board, that there was a lot of common themes from the states that we talked to and included in the toolkit case studies. The first one was, of course, continuing stakeholder engagement and actually thinking about post-launch how to refine approaches to maintain support from key partners and interested stakeholders at the state level. There was a lot of interest on the part of states to learn from either experience where they didn't have mechanisms in place before launch for how they would collect baseline data for their programs, or they were thoughtful and really found a key piece being to act on program evaluation visions early in the design of these programs, so that states would be in a better position to compare the experience of beneficiaries pre and post launch. That is not the easiest thing to achieve based on the complexity of data that exists out there and that states could be examining. So states have really focused as well on thinking ahead of time about what data they can require from their health plans with these programs, and collecting that data in a timely manner to use for both risk adjustment, resource allocation, and monitoring and evaluation work. The last thing that I was going to point out here before turning things over to Tammy is that there is another, I think, very common theme across states, which is considering phasing these programs in. Given the vulnerable nature of the populations that are being enrolled, the complexity of the care array that folks receive, States have found significant value in phasing these programs in, whether by provider type, enrollee population, and or geographic region. And that has, again, been a universal approach we've seen. So I am now going to ask us to advance to the next slide and would be happy to welcome Tammy Whitlock, who's the Director of Integrated Care at Virginia's Department of Medical Assistance Services, to talk about some of their work on advancing LTSS integration in Virginia.
Thanks very much. In Virginia, we did start our MLTSS program, which is the Commonwealth Coordinated Care Plus program, in August of 2017. And we used a 1915 BC combo for our authority. We included individuals who were in nursing homes. We included individuals who are in our waiver for that encompasses personal care and adult day healthcare services and respite. And we also included individuals who were in our technology assisted waiver. We do have individuals in our IDDD waivers. We have 3 IDDD waivers. They are in, as was referred to earlier, for their acute and primary services, or basically everything except for their waiver services. At this point, we do have plans in the future to roll that group in, but I don't have a date yet on that group. We used a phased-in approach in 2 different ways. We used a phased-in approach to roll in the numbers of people by region starting in August, and we basically had 6 different implementation dates, which sounds like a lot, and it was, but we did that for a variety of reasons. For example, in August, September, October, November, and December, we rolled in our 5 regions across the state, and that encompassed about 100,000 individuals. And with each region, we were able to look at how that rollout went. For example, when we went from August in our Tidewater region, and we went to enrollment in the Central region in September, we were able to adjust not only how we communicated our efforts out to the public, but also we had some issues with file transfers and with provider files that were loaded into our system that we didn't anticipate. And by being able to look at it one region at a time, we were able to fix those issues prior to going into the next region, which was very, very helpful. The other thing that we did as part of the phased-in approach is we did town halls the month before each rollout in each region. And we actually learned through those town halls every month. The first month that we did the town halls, and I actually did the ones personally in Tidewater, we were able to come back and say, wait a minute, we need to change our messaging a little bit because we're getting these kinds of questions, so clearly we aren't getting across what the purpose of the program is, or people are missing that transportation is included, or anything like that. So we were able to, by rolling it out region by region, we were able to adjust our message and our communications. The last rollout that we did was another 100,000 members. We have 210,000 members in our CCC Plus program right now. And on January 1st, after all the regions had rolled in, we also took on our age, blind, and disabled individuals from our currently existing managed care product, which is our Medallion 3 product. And that's been in existence for about 20 years. So we took those members and transitioned those members all at once on January 1st. And we also transitioned our former dual demonstration members on January 1st. The other thing that occurred on January 1st, as we're talking about integration, is that we included our community mental health services, which have historically been carved out of every managed care product we've had. And that was quite an undertaking, and I will say that has been something that has required an extensive amount of work. We did do a lot of transition work with our ABD population in January, hand-holding and making sure that they got to the right place and got their services covered. but the community mental health, being a brand new service that has rolled in, has been quite an effort to put those services into managed care. We really felt like, though, it was important to integrate long-term services and supports and behavioral health all together with our acute and primary services because, well, number one, it always helps when your General Assembly directs you to do that. The second piece of it, though, is that we really felt like, and with, following in the steps of Tennessee and Minnesota and Arizona and other states, we felt like there was a lot of room for better outcomes for our members. Prior to us pulling all of these services under one umbrella, it was really a bifurcated system, and the members didn't have a one-stop shop. They really had to navigate on their own. In addition to the integration, one thing that we were able to do is pull in a care coordination model for all of our members. So we have a requirement in our contract that each member has to have a care coordinator. The health plans are allowed to stratify those members according to their needs, but we felt like it was important to pull in a strong care coordination model with ratios and specific requirements, because a large part of our membership really have been floundering without the ability to have a care coordinator or a case manager. In our tech waiver population, we had some strong case managers here within our agency who managed those cases. But in the community, with our other waiver, a very large waiver that has about 26,000 members on it, that we didn't have the component for care management. And so we felt like the health plans, having everything under one umbrella, would have a really good opportunity to help the members navigate the system and make sure that we're reducing duplications, that we're handling questions as they arise, and the membership is just not out there. Our former director, Cindy Jones, used to call fee-for-service fend for yourself. And so we really wanted this to be a different approach and have the ability to have our members have this information and have a contact. We felt like, as far as doing it incrementally, I've talked a little bit about that, but the other thing, not only did it allow DMAS, our agency, to make adjustments, it allowed the health plans to make adjustments from region to region, which was really an important message for them. They got to see that each region is a little bit different and that they needed to make adjustments in their care management system, in their training, in their networks. I will also say that we learned from our dual demonstration that incorporating Medicare is a big component, and Virginia does require all of our Medicaid plans to be DSNPs by January of 2019. 5 out of our 6 plans are already DSNPs. So we're hoping to see some good alignment there, to have a one-stop shop for our members who are duals, to allow better cost savings and care coordination across the two benefit plans, and just to reduce fragmentation for the services. So I know we are close to time, so I'm going to stop there so that we have the ability to answer questions. I hope that was okay, CHCS folks.
Hi, Tammy. This is Michelle. That was wonderful. If we could have the next slide, I'm going to wrap this up very, very quickly to turn to 1 or 2 questions. Just first, we wanted to thank the Milbank Memorial Fund and the SCAN Foundation again, and we have some conclusions. I won't go through all of them now. The slides will be available on the website, but I think just that the one I wanted to highlight is that these strategies that many of the states discussed through developing the toolkit and on the webinar today is really thinking about creating a vision that transcends administration and policy priorities, that low-income adults who need and use LTSS are a high-need population, and they are a fast-growing population. So the demand will continue to grow, and the states that we featured have developed strategies that will be long-standing and flexible enough to grow with the demands of the population. So thank you, Stephanie, Alex, Patty, and Tammy, and I will turn to questions, which we can hopefully get to a few of before we have to drop off.
Thanks so much, Michelle, and thank you to all of our panelists. This is Alex with CHCS again. I think what we were going to do is we did have just a few questions that came in, but for sake of time, what we'll do is we will follow up individually with the attendees who had some particular questions, because I know that our panelists and we would like to answer those for you. And then we wanted to go ahead and thank you again, as Michelle did, for joining the webinar today. We wanted to remind folks that there is an online evaluation survey that will pop up because you've joined the webinar, and we'd love to get your responses and your feedback so that we can refine our webinars going forward. And again, thank you to our state perspectives from Virginia and Tennessee, both Tammy and Patty, for the valuable insights and information that you shared on the webinar today. And thanks to everyone for joining.